What would an ideal oral health ecosystem look like? In a perfect world, you and every other person would have access to quality, affordable oral health care and would understand the importance of regular care. No matter where you live, what you do, how much you earn, what language you speak, or what your life circumstances are. Today, too many North Carolinians face serious barriers between themselves and the care they need. Barriers such as a lack of disability accommodations, language barriers, anxiety, fear, and shame, health literacy, transportation access, structural and interpersonal racism, the distribution of dentists, rising insurance and care costs, and much more. Breaking down these barriers and building a more perfect ecosystem is what NCOHC is here to do, and we need your help. With a diverse coalition oriented toward positive change, we will build a better oral health ecosystem together. One with public policy developed with community to work for the people, breaking down barriers and building a more accessible oral health landscape for all. That rethinks the way we pay for care, supporting the whole person and taking into account everything that may impact the care you receive, like transportation access, food security, and more. With actively engaged and supported communities, continually working to improve oral health, putting the patient at the center of care. Together, we will build a more perfect oral health ecosystem. Learn more and join the movement today.
Welcome, everyone. Good morning. This is so exciting to have you guys here with us today for our 5th annual Oral Health Day. This is our 2nd year doing this virtually, and so unfortunately, due to COVID, obviously we're convening together virtually this year instead of down at the General Assembly. But we're thrilled to have you with us this morning to kick off our event. Although the event is obviously virtual, I'm sure that the panelists and the speaker content that we have geared up for you today is going to be very engaging and a very high impact agenda. I do want to go through just really briefly the agenda that we'll go through today. So we're going to kick it off with Rear Admiral Dr. Timothy Ricks, who is the Assistant Surgeon General for the U.S., where he will be giving a national perspective on the state of oral health in America. Then we will have a very state-specific content presentation around collaborative approaches to evidence-based reform. Then handing it over to Dr. Amy Martin, who is a professor and chair at MUSC, and then to Dr. Bill Donigan and Melissa Boughman at Kintegra Health. I do want to make sure that everyone has a chance to ask questions, so make sure that you do use the Q&A feature. If you navigate to the bottom of your screen, you should have an option that says Q&A. Please submit your questions throughout the event. We will be having team members monitor this to make sure that we answer live. And then we will have a dedicated carved out section of the agenda as well to answer any questions that we didn't get to throughout the event. For those that have questions that we do not get to during the event at all, we will actually follow up with you personally to make sure that those are addressed. So don't miss the chance to ask our stellar speaker lineup any questions that you may have. I want to take a moment to recognize our stellar team at NCOHC. So we have Sarah, our program coordinator, Brady, our content marketing manager, and Ben, who is our political strategist. And I do want to take a moment just to thank them for all the hard work that they put into this event. Definitely, the event would not be possible without their efforts. Speaking of Brady, if you should encounter any technical difficulties during the event, he is your go-to. And so his email address is listed at the bottom of the slide. Please make sure that you reach out to him and he will get you squared away. As well as Sarah, she's going to be raffling off gifts for participants during the event. So we do have some goodies for you guys that she will be reaching out to you live to get contact information and let you know the prizes that you've won. We have a couple things. We have North Carolina specific gift baskets, all with North Carolina products to support local businesses, as well as 2 Sonicare toothbrush kits that we'll be raffling off. All right, with that out of the way, we're thrilled to introduce the keynote, Rear Admiral Dr. Timothy Ricks. Dr. Ricks is a passionate oral health champion, currently serving as the 20th Chief Dental Officer of the U.S. Public Health Service, as well as serving in the role of U.S. Assistant Surgeon General. As if these roles were not occupying enough of Dr. Ricks's time, he also serves in various capacities with the Indian Health Service, including as the Continuing Dental Education Coordinator, the Expanded Function Dental Assistant Coordinator, the National Oral Health Surveillance Coordinator, and the National Oral Health Promotion and Disease Prevention Coordinator, just to name a few. So with that in mind, he's going to be speaking on the current state of oral health, addressing health inequities and barriers to access, as well as COVID-19's impact on oral health and the oral health care delivery system. Please join me in welcoming Dr. Timothy Ricks to Oral Health Day 2020. Tim, it's all yours.
Thank you, Dr. Brian, and thank you all for joining today. It is an honor to be with all of you. This picture is from my last visit to North Carolina back in 2019. And, you can see Dr. Brian there. You can see Dr. Tomlinson on the far left, your state dental director, and other key stakeholders in North Carolina as well. And I hope to make it back to North Carolina in person. Like you, I'm growing weary of Zoom events, but we're doing the best we can. And I applaud Dr. Brian for holding this event. I'll say after having visited about half the states that I hold North Carolina's Oral Health Collaborative Coalition as one of the best, if not the best in the country. So kudos to Dr. Brian and his team for all the work that they do to improve oral health in North Carolina. So what I'm going to do is talk about various things related to the current status of oral health in the country at a national level, but I have nothing to disclose as far as financial relationships, and I do include references. But before I start with the content, I always have to talk a little bit about the U.S. Public Health Service. Our official motto is in officio salutis, which we translate from Latin to mean in the service of health. We go back about 200 years. Our mission is to protect, promote, and advance the health and safety of our nation. And we do this through providing essential healthcare services to vulnerable and underserved populations, through being deployed for public health and natural emergencies, hurricanes, 9/11, we were deployed. This picture on the right is a deployment to West Africa for the Ebola outbreak. And of course, the Public Health Service has been at the forefront of this ongoing pandemic. We also lead public health programs through the federal government and advance innovation and science. Dentists in the Public Health Service serve really in three departments. In the Department of Justice, we have dentists in the Federal Bureau of Prisons. Within the Department of Homeland Security, we have U.S. Public Health Service dentists in both the Immigration and Customs Enforcement Health Service Corps, about 14 different facilities, and 26 facilities in the U.S. Coast Guard. Primarily, though, we're in the Department of Health and Human Services, where we have dentists serving in the Food and Drug Administration, the Health Resources and Services Administration, Centers for Medicare and Medicaid Services, the Centers for Disease Control and Prevention, National Institutes of Health, and the Indian Health Service, where I'm at, where we have about 350 different facilities. I often say that we in the U.S. Public Health Service are really the intersection between different components in oral health. From a global perspective, I represent the U.S. In interactions with FDI, with the World Health Organization, with PAHO, and with some of our allies. Within organized dentistry, I network frequently with organized dentistry, the ADA, the Association of State and Territorial Dental Directors, the American Network of Oral Health Coalitions, and many, many others. On the regulatory side, we interact with the American Association of Dental Boards, OSHA, and the FDA, And then on the federal level, we interact, U.S. Public Health Service dentists interact with other U.S. Public Health Service disciplines, as well as our military counterparts and all of the aforementioned agencies. So let me start. So that's a quick view of the Public Health Service. Let me start the content with talking a little bit about COVID-19 oral health. As many of you know, states one by one were allowing dentists to do COVID testing and vaccination, and dental hygienists as well. And I believe there are 18 states that allow dental hygienists to do administer the vaccine. And up until March the 11th, there were 24 states that allowed dentists to do so, either through executive actions or through state board temporary rules or so forth. But back in March, the federal government jumped in and amended the Public Readiness and Emergency Preparedness Act, or PrEP Act. And this was effective March the 11th. And this authorized all dentists and all dental students, as well as some other healthcare professionals, to administer the COVID test and the COVID vaccination. So every dentist listening and every dental student listening to this has the ability, free of liability, to administer the COVID vaccination. States are requiring certain trainings and so forth, but you do have that authority. The real question we have, and I don't know if I can answer this or anyone can, is what has been the impact of COVID with those who are the most vulnerable and underserved in our country as far as oral health? What we know is, and this is from some old data from the Agency for Healthcare Research and Quality, or ARC, is that about 70% of Americans that go to emergency departments with dental pain or dental infection being a top concern, about 70% are either uninsured or underinsured with Medicaid. So about 30% Medicaid, 40% uninsured completely. We also know that dental pain or infection as a chief complaint in emergency departments is actually a small portion, less than 3%. However, for chronic users of emergency departments, people that keep going back, it's substantially higher. So those that go to emergency departments 20 or more times, dental problems are about 26% of the visits in the emergency department. Those that have 30 or more ED visits, about 25% go with the chief complaint of dental. So it is for these that are chronic users that probably don't have dental homes or even medical homes, they're more likely to have dental concerns. We also know that starting in mid-March, as the pandemic really exploded in this country, the emergency departments really battened down the hatches and started really focusing on real true emergencies in their emergency departments. And as a result, that plus people's fear of contracting COVID in emergency departments led to a very steep decline in emergency department visits related to dental pain. So this graph just shows dental pain as a chief complaint in emergency departments in 2020. And the x-axis is by week. So around week 11 or 12, you see this huge decline in emergency department visits related to dental pain, which I drew an arrow on. But even after that, you can see pre-COVID on the left of that arrow. And then the rest of 2020, you can see it never rebounded. And I've got that highlighted with the red. It really never rebounded to the level it was pre-COVID, at least in 2020. We saw the same thing with children on Medicaid. And we saw as dental programs across the country stopped routine care in March, most of them, 95% of them did, we saw this huge drop in children's Medicaid dental services. So just to explain this graph, the top two wavy lines are 2018 and 2019. These are dental services per month that are given to children with Medicaid, averaging between 3.5 to 4 million per month. So you can see that dropped to less than 500,000 in March of 2020. What's interesting is it really never, it didn't rebound to pre-COVID levels. So again, if you look at the length of time that I've highlighted in the red, you'll see that it rebounded to around 3 million, maybe a little bit less in the latter part of 2020. So about 80% of pre-COVID levels. And why is this important? Again, these are the most vulnerable and underserved people in America, the children with and adults with Medicaid, but this was looking just at children. So that's a good segue into talking about oral health inequities and the things that drive inequities in our country. C. Everett Koop, which many of you know was the Surgeon General in the 1980s, 13th Surgeon General, said, "You're not healthy without good oral health." But I want to start with a little bit of a definition, making sure that we all understand what equity really is. So the picture on the left, and you've probably seen different versions of this, it's a father and his two sons watching a baseball game, looking over a fence. So equality is where everyone is given the same resource. So in a dental world, maybe let's give everyone $5,000 to get them to oral health. Well, the truth is, I mean, if you look at this, this is a good example. If everyone gets the same care, then the man that didn't need the box can still see the game. The older kid can see the game now because he has a box to stand on. But the one that needed the most resources, the little kid, the youngest son, still can't watch the game. On the right side is what equity is about. Equity is about allocating the correct resources to those that need it. So the older man really doesn't need a box to watch the game, so he's given nothing and still can watch the game. The older son can watch the game with one box, but the younger son now can watch the game because he's given twice as much. And that's what equity is all about, is making sure that there's a fairness so that health or oral health can be achieved by all. The CDC defines equity as a disparity that is, or inequity as a disparity that's due to differences in social, economic, environmental, or healthcare resources. And it brings up this whole idea of justice, fairness. So that's what differentiates an inequity from a disparity. A disparity is simply a difference in disease status or health status rates between two different groups. And inequity is explaining why that disparity exists, what the resource allocation is. So this is a report from the Centers for Disease Control and Prevention published in 2019 based on the National Health and Nutrition Examination Survey data. And it looks at, across the lifespan, different disease characteristics. So caries prevalence is any history of dental caries, including failed or missing teeth. Untreated decay obviously is active disease, and tooth loss is self-explanatory. But the conditions across the lifespan are in the columns at the very top. When you look at these conditions, and look by race and ethnicity, what you'll see is that Black, non-Hispanic Americans and Mexican Americans suffer disproportionately from these different dental diseases compared to white non-Hispanic Americans. And in some cases, it's double the prevalence. And I've put those all in a red color. Similarly, if we look at income, those who are living at or below 200% of the federal poverty level, or FPL, suffer disproportionately when compared to those living at or above 200% of the FPL. So essentially, the very poor versus the middle class. And again, you can see that the prevalence of disease in some cases is 2 to 3 times that compared to in the poor compared to the middle class. Even in older adults, we see this as even more significantly. And, you know, there's been a lot said about how more people are retaining teeth and so forth, but it really is the haves and the have-nots. So if you look at the functional dentition, which is defined as 21 or more teeth, wherever they're located, among adults 65 years and older, what you'll see is back in the late 80s, early 90s, 16.7% of the poor and 38.3% of non-poor had a functional dentition. So the disparity between the non-poor and the poor was about 22%. Fast forward to the latest data we have on this subject, and you can see that both groups improved. The poor went from 16% to 25%. The non-poor went from 38% to 68%. And what you'll see, though, is that the disparity, which I've highlighted in yellow, has actually more than doubled between the two time periods. So even though oral health may be improving in America, it's not improving at the same rate for everyone. One thing that I like to point out is that when we talk about integrating oral health into primary care and vice versa, it truly is a bidirectional nature. There are 108 million Americans that see a medical provider each year, but not an oral health provider. Conversely, there are 31.1 million Americans, including 700,000 children under the age of 4 years, that see a dental provider, an oral health provider, but not a medical provider. So when we're talking about opportunities to do point of care testing, depression screenings, hypertension screenings, diabetes screenings, HPV or other vaccination education, oral health professionals certainly have that ability to do and may actually reach a significant number of people that don't see a medical provider. When we look at access to dental care by race and ethnicity, what you see is that the gap between white Americans and minorities is much higher in adults than it is children. So if you look at the graph on the left, this is the percentage with a dental visit in the last year. And the burgundy color, you don't have to pay attention to the differences from 2 different years. But the burgundy color is white non-Hispanic Americans. The teal color is Asian Americans. The green is Hispanic Americans. And the orange are Black Americans, Black non-Hispanic Americans. And what you'll see is that the disparity, which I've highlighted in yellow, really is between Black American children at 42% and white non-Hispanic Americans at 55%. So it's only about a 13% gap. If you look on the right side, you'll see with adults, it's much more pronounced. So 48% of white non-Hispanic Americans access care. But if you look at Hispanic Americans, only 27% access care. So there's about a 20% difference. And I've highlighted that in yellow as well. So the difference is, of course, as we all know, is the Children's Health Insurance Program, or CHIP, and Medicaid for children have really been the game changer to bring about more equitable access to care. I'll talk about adult Medicaid in just a few minutes as well, but I want to remind everyone that there are 60 million people living in a dental health professional shortage area. HIPSAs are designated by the Health Resources and Services Administration for primary care, mental health, and oral health. There are about 6,500 HIPSAs, dental HIPSAs across the country, and they're shaded in various shades of purple here, including the vast majority of North Carolina, as you can see. HRSA estimates that it would take almost 11,000 oral health practitioners to go out into these areas to remove the HIPSA designation. Now, understand with HIPSAs, this doesn't mean that if you look at a particular location that's dark purple, that there are no dentists. It just means the dentist to population ratio is small or too large. We also know that there is a significant difference by state. So the national average is 60.89 dentists per 100,000 population. The highest is New Jersey, and you can guess the other high states, New York, California, Texas, et cetera. But New Jersey's 81 dentists per 100,000. Arkansas is at the bottom end at 40.93, and North Carolina is actually toward the bottom at 50.17 dentists per 100,000. I'd be remiss if I didn't at least mention some of the factors that affect access to care. And you should know this, but obviously poverty, which I mentioned earlier, food insecurity, housing stability or housing insecurity are all very important factors that affect access to care. Education level, literacy, obviously, is very important to their patients' understanding of oral health, as well as their ability to be equal partners in healthcare decisions. And of course, there are things like discrimination, incarceration, civic participation that affect health, and things like that, how their environment, the prioritization of dental care in the community, in their family, quality of housing, access to healthy foods, and so forth. And I'll just briefly mention, Dr. Bryan, I believe, spent some time working in the Indian Health Service. And I remember my first assignment was in Nevada, in northern Nevada, and the reservation where I worked, the only thing that they had nearby was a convenience store. So, and this was 25 years ago, where those convenience stores didn't have bananas and oranges and things like that in it. It was mostly a sugar aisle and a salt aisle. And so when when they'd come to my clinic and I'd talk about making healthy food choices, for some, there just wasn't an opportunity to make those healthy food choices. One of the things, the big drivers of access, is the cost of dental care. Dental care has gone from a $60 billion industry 25 years ago to $120 billion today. Per capita cost of $232 back in 1990 to $413 in 2018. And because of that, more people are willing to forego dental care than any other type of health care, with this almost 10% saying that they did not get dental care in the past year due to the cost of care. So that is a significant barrier, especially for those living at or near poverty. So I'll shift gears a little bit. So I've talked about some of the access barriers, but I want to talk about some potential solutions with regard to workforce and some additional problems. So we've had in the US over the last 25 years, a 22% increase in the number of dentists. Now, this is due to several things: increased dental school enrollment, sizes of classes, the increase in a number of dental schools to now I believe we're at 66 and there's another one on the way, and also delayed retirement from dentists pre-COVID as well. So a 22% increase, but in reality, it's a much more modest increase of about 6% when you look at population growth. Where do these dentists go? Well, most of them have about $300,000 in debt upon graduating from dental school, according to the American Dental Education Association. And that translates to about $700,000 after it's paid off over 25 years. So this is a huge driver of where these dentists go. This is why New York, New Jersey, and California and Texas and urban areas have so many dentists, because they have all of this debt, and that debt drives where they go. Another thing that we've seen is a shift. We've been about 2 decades behind our medical counterparts. Back when I was in private practice, about 2/3 of dentists were in solo practice. Now that's only about 1/4 of all dentists. And most dentists are either in non-dental support organization affiliated group practices or in DSOs. And DSOs, the dental support organizations, that's corporate dentistry. And this graph shows back in 2016, about 8% of dentists were in DSOs, but it may be closer to 15 to 20% now. Another model regarding workforce is dental therapy. This began in 2000 as the New Zealand dental nurse model was brought to Alaska in the Indian Health Service. And now there are active dental therapists working in tribal lands in Alaska, Washington State, Oregon, and Idaho. And there are also, Minnesota became the first state to authorize dental therapy in 2009. So there are a significant number in Minnesota as well. And I believe Maine also has a practicing dental hygienist therapist. But there is no universal model. There are 12 states that have authorized dental therapy, and the models are all a little bit different. So I think what I would say in closing about dental therapy is just to keep an open mind, look at the model, look at the what they can do, their training and so forth, because it certainly in Alaska has significantly improved access to affordable and culturally competent oral health services. We've also seen in the past 2 decades an expansion of the scopes of practice for dental hygienists across this country. And what this wheel has is every state and divided up by region. And the more colors, basically, the broader the scope of practice. With the pink being diagnostic, dental hygienists making diagnoses, and the purple giving them prescription authority, which are the 2 broadest things in the scopes of practice. What you'll see here, though, if you look at North Carolina, if you look at the Southeast has the narrowest scope of practice for dental hygienists, and North Carolina and my home state of Mississippi and Alabama and Texas all have the narrowest scopes of practice for dental hygienists in the entire country. And I borrowed this graph or this map from the North Carolina Oral Health Collaborative, so thanks for this. But there are 14 states now, excluding North Carolina, 14 states that credential expanded function dental assistants. And for those unfamiliar, there are various types of expanded function dental assistants. The most common is the restorative EFTA, which actually began in the Indian Health Service in 1961. And that's where the dentist will prepare the tooth and then move on to another patient while the dental assistant will go in and restore the tooth. So they're working under the indirect supervision of a dentist. The dentist is still in the building. There are also other types, orthodontic EFTAs, periodontal EFTAs, oral surgery EFTAs, and so forth. Another alternative workforce model was the Community Dental Health Coordinator model, or CDHC. This was created back in the early 2000s by the American Dental Association. There are now 9 states that use this model fully, and there are other states that are exploring this. But a CDHC does exactly as the name implies. They coordinate dental care. So most of them are dental hygienists. There are some dental assistants, but they go out into the community or are affiliated with a practice like a federally qualified health center, and they will reach out to those vulnerable and underserved people in the community and help find dental homes for them or refer them to the proper places to get their oral health care. They can also do all the things a community dental hygienist could do: sealants, fluoride, anticipatory guidance, motivational interviewing, and so forth. Now, I told you I'd talk a little bit more about Medicaid. So let me talk about Medicaid participation. And what we see is that minority dentists are more likely to be providers of Medicaid. Women dentists are more likely, and young dentists are more likely to be Medicaid providers. On the bottom, you'll see a bar graph listing each state and the percentage of dentists that are Medicaid providers, with a low in New Hampshire of just 15% to a high in Iowa, which is 77%. And you'll see North Carolina, which I've got an arrow pointed to, is toward the bottom with only about a 35% rate of dentists participating in Medicaid. And again, I just go back to that other graph of HPSAs and remember that the majority of North Carolina is a designated dental health professional shortage area. And many of these are vulnerable and underserved children and adults. There are 74 million Americans who lack dental coverage. There are 19 states now, not 18. There are 19 that have reimbursed for comprehensive dental benefits, which means basically that the Medicaid program will pay for 100 or more procedures. North Carolina is one of those that does that, which means that even though we understand the reimbursement rates are lower, this means that there's an opportunity in North Carolina to increase that Medicaid participation rate among dentists, because Medicaid does provide extensive coverage for adults. And that is it for my presentation. And I'll be happy to answer questions in the Q&A function or in a few minutes after the other speakers. But hopefully this has given you some insight into what oral health inequities are and how what some of the drivers are for access to care and opportunities on the horizon with regard to alternative workforce models. So thank you very much. I look forward to listening to our other great speakers, and I'll turn it back over to you, Dr. Brown.
Tim, thank you so much. The presentation was wonderful, as usual. So thank you for agreeing to open us up for the event today. Okay, so now we're going to move on and kind of dovetail off of Dr. Rix's content to talk specifically about North Carolina. So he gave a national perspective, and we're going to dive in just a little bit to talk about our state inequities. There are a lot of great questions coming in through the Q&A, so keep those coming. We will answer those live. Either the speakers can answer directly, or we will hold those to the end for the speakers to answer verbally for you. But we had about 35% of new participation or new engagement this year in our Oral Health Day, which was fantastic to see. And those 35% of participants are not or have not previously engaged with our work at the collaborative. which we're thrilled to see. So I did want to just provide a really brief overview of the North Carolina Oral Health Collaborative for those that may be new to our work. So at NCOHC, we are a program of a larger nonprofit called the Foundation for Health Leadership and Innovation. And we are truly driven by the desire to create a model of care in a systems redesign approach. We do that to support policy changes, empower community, and really accentuate and focus on prevention and health literacy. We know that to create the system of change that we really want to see, we have to engage both traditional and non-traditional stakeholders in the conversation and make sure that we center community in that decision making. So I want to thank all of you again for being a part of today's event, and we do hope that you will continue the engagement with us following the event. To that end, you met our team earlier. I briefly introduced them, but they work tirelessly across all health sectors to actualize our goals. And then obviously at the center of our mission is making sure that we effectively engage community in that conversation. So if you all have seen a presentation from me in the past, you know that I love Mary Otto. And so I put a quote in from Mary Otto. She is a journalist and author of the book Teeth. I do highly recommend that you all reach out and get a copy of that book. If you're interested, happy to loan one out to you as well. Even I'd be happy to mail it to you. But her quote says, "We cannot drill, fill, or extract our way to better oral and overall health. We need a fundamentally different approach, one that accentuates disease prevention and health management using a multidisciplinary approach that's integrated and patient-centric." I could not agree more with this statement. And this really is really kind of the mantra that we live by at the Oral Health Collaborative, making sure that we focus on prevention, as I mentioned, but also engage a multi-sector approach to the solutions that we put forth. We know that we are much better, more effective through collective action. So why do we exist? As we've gotten to know many of you over the last several years, I can't tell you how inspired we have been listening to your lived experiences of understanding the barriers and inequities that you face every day, or the communities in which you work and advocate on behalf of face every day. So in building off Dr. Ricks's fantastic presentation, I do want to start diving into some of the state-specific inequities that we face here in North Carolina. So goes without saying, I know many of you are familiar with these very unfortunate statistics. When I see unfortunate statistics, I take it as an opportunity to really drive solutions forward that will address these. But we have some real workforce challenges in our state, both in terms of utilization, particularly with our dental hygiene workforce, but also in distribution. You'll see in a map here in a couple slides just how heavily concentrated dentists are in urban and suburban areas and really away from the rural communities, which makes up almost 40% of North Carolina. So Dr. Ricks mentioned the DHIPSAs, or the health professional shortage areas for dentists nationally, and I want to show you really what this looks like in North Carolina. So in about 2017, we had 74 out of 100 counties in North Carolina deemed a DHIPSA. And then in 2019, early 2020, HRSA, the Health Services and Health Resources and Services Administration redesignated North Carolina and gave us a 98 out of 100 county designation for DHIPSA, which was really alarming and sad to see. And then following up on that, as of November of 2020, they have now deemed all 100 counties in North Carolina as a DHIPSA. Now that's either full county designation or partial county designation, as you will see with Wake County on the map here that's white. That is only a partial designation. So when we fade out and actually look and overlay a map of where dentists are choosing to practice, it goes, should not shock anyone, but they are concentrated in urban areas. So I made sure to put the highways and urban centers on this map to show you just how heavily concentrated dentists are in urban centers or along highway systems and away from rural communities. The darker green means a higher concentration of dentists per 10,000 population, and this data is from UNC Shep Center in 2019. So take a moment and just think about that. So how are we going to address shortages? We are obviously potentially opening another dental school in North Carolina, so there will be 3. And we're seeing tremendous growth in terms of number of dentists moving and becoming actively licensed in North Carolina to practice. But we also, meanwhile, need to ensure that we are branching out into community and meeting people where they are, which is going to be a theme for my content today, is really thinking about how do we, get out of the idea of dentistry can only be delivered or dental hygiene only delivered in the traditional 4 walls of a dental office, and think about how we can expand access into alternate setting types. So when you look at the growth, this was a study done by UNC Shep Center that ended in 2017. In following up with them, it seems that this trend is still occurring, which again, I don't think will shock anyone, but I did want to make sure that we put this content in today for you all. 72% of North Carolina's dental workforce growth occurred in just 5 counties, just 5. So we have 100 counties in the state, and just 5 had the most growth in terms of actively practicing dentists. That occurred in Buncombe, Mecklenburg, Orange Pit, Wake. So Raleigh, Chapel Hill, Greenville, Charlotte, and Asheville. Probably again will not shock anyone, but it is really important to ensure that we track these trends and start to address with some innovative solutions to again expand service scope and expand service delivery in alternate settings in other communities. So Tim, you had this wheel. I call it the wheel of opportunity. Some people call it the wheel of misfortune. But either way, we are making some strides. And so you all may be familiar with a regulatory rule change called 16W that the North Carolina Oral Health Collaborative worked in partnership with the North Carolina Dental Society and many other stakeholders to accomplish, that went into effect into law in February of 2020. Prior to this, dental hygienists outside of those at the oral health section that did have special provisions to be able to deliver preventive services in community without a dentist prior examination, hygienists were really limited in direct access to patients. And when I say direct access, what I'm referring to is that a hygienist can establish a relationship with a patient, deliver preventive services, and maintain that relationship, not independent of the dentist. That is not what I'm saying, but they're able to do that more freely with indirect supervision and so forth. So I'm very happy to show that my skills on paint, I'm sorry that it's not perfect, but we did start coloring in those boxes. And so we now obviously have direct access to prophylaxis and provision of delivery of sealants. I know that there was a question in the Q&A, and I hope, Kay, that this answers your question. But yes, hygienists are able to deliver those preventive services that are much needed in high need settings under both 16W as well as another rule change in regulatory called 16Z. Now, as we look at utilization, Dr. Ricks talked about utilization in our Medicaid programs nationally. I want to dive in a little bit more heavily into North Carolina specifically. In 2020, a report was released by the Health Policy Institute with the American Dental Association, or the ADA. And unfortunately, the report underscored just how low our utilization of dental services by beneficiaries is. When we look at this map, this is for children. This is utilization of Medicaid services by children. The red area denotes low Medicaid utilization as well as low meaningful Medicaid provider supply. So the way that meaningful Medicaid providers are defined in this methodology for this map is based on an annual threshold of billing. So it's an amount that the provider bills annually for Medicaid beneficiaries or Medicaid services. I would challenge and really urge us to look at the full picture in terms of how that equates to access. And so as you see, even on this map, the perimeters of the state have low utilization as well as low Medicaid provider supply. And then the interior of the state has above average Medicaid dental utilization for children. Now, as we flip to look at this, the same map, but for adults, we see a similar picture. What I really want to make sure that to underscore is the common theme across the maps that I have already shown you. So when you think back to the maps of concentration of dentists, you're going to see two major themes based on utilization, and that is participation of providers in the maldistribution across the state that has occurred. So we really do, as a stakeholder group, really need to consider how we are going to make very high impact changes that will reverse this trajectory. We hear on a daily basis from community, unfortunately, just how difficult it is for them to find a provider. I mentioned earlier specifically that this may not tell the whole picture about meaningful providers. And the reason I said that is because there are a lot of times that Medicaid providers are no longer seeing new Medicaid patients, or they may not be seeing Medicaid patients, but only for 2 days a month. When we think about vulnerable populations, you all, I really want to emphasize just how complex the barriers are that they face to be able to achieve access to dental services. So we have about an estimated 35% of North Carolina dentists that accept Medicaid or CHIP, but please do remember again, I look at that from a holistic approach to access. Being a Medicaid provider, but not seeing new Medicaid patients, that's still impeding access. And I want to be on the record to say I'm not criticizing any providers, whether they participate or not participate in Medicaid. I'm just wanting to showcase the facts so we can all be on the same page to make sure that we can address these concerns collectively. When we look at utilization by adults, so that was the last map with the colors that I showed you, the utilization is about 18.7%, which is below the national average of 23.2%. And really, even looking at the national average, that's much lower than we would like to see. And again, in credence to the whole holistic picture, that's also complex. And so sometimes it is an impedance of direct access to have for those services, but it can also be all of the social determinants of health that Dr. Ricks mentioned earlier, and I'm going to re-showcase in a slide coming up. So it's really important to look at how social determinants of health drive inequitable outcomes. So rural and marginalized communities do disproportionately lack access to oral health, and as a result, suffer worse oral health outcomes. When we look at racial and ethnic disparities, this is very telling in terms of outcomes, but you will see a huge difference, obviously, between African American, American Indian, Hispanic, Latinx, and white non-Hispanic folks across our state in terms of outcomes. So the blue bar shows the percentage that have folks that have not visited a dentist or a dental clinic within the last year. And we see that the highest group obviously is Hispanic and Latinx at 51.2% compared to 32% of white individuals. The purple bars have had any of their permanent teeth removed. So that means any removal of teeth. You'll see that 45.5% for white individuals, 58.5% for African American. And then the orange bar shows have had all of their natural teeth removed. This is significant. So we're talking about removing all of their natural teeth. 16.7% of white individuals compared to 24.6% of African Americans. Unfortunately, the survey data did not include that statistic for American Indian or Hispanic Latinx populations. I would say lagging rates of dental visits among these populations are also a reflection of systemic inequities and disparities, as well as the social determinants of health, which we're going to, again, dig into here in a second. When we look at disparities by income across North Carolina, this is a self-reported survey that was conducted by the Health Policy Institute with the ADA back in 2015. I would still argue that this holds true today. But when you look at income level, low income versus high income, you see a huge difference in terms of self-reported overall condition of the mouth and teeth. That is how the question was asked. So for low-income individuals, 16% reported very good, that they would say that their overall condition of their mouth and teeth is very good, versus 35% that in the high income group that said that they would self-report that the overall condition of their mouth and teeth was very good. So there's a huge disparity there, and we see a stark delineation by income level. Dr. Ricks did mention some of the barriers to oral health care as well, but this is by income level. And so the highest, which is the dark teal, is cost. And then afraid of the dentist is the light blue, inconvenient location or time is orange, and then in green, trouble finding a dentist. So in reviewing barriers to oral health care by income level, the previous slide, becomes even clearer. So for those with low socioeconomic status, the cost of dental services and inconvenient location and time of dental access points remains two of the largest barriers that we see. So in terms of social determinants of health, particularly in the context of the previous slides that we've talked about in terms of disparities, it really is critical that we consider just how complex they are. I often hear, and this makes me very sad to hear this, but I hear sometimes folks say, well, if, the individual wanted oral health care services, they would seek them out. The market will self-adjust. Well, I'm sorry to say the market will not self-adjust, particularly for individuals in vulnerable populations that have very complex barriers that they're overcoming or facing. And some of those have already been touched on, but I wanted to make sure that we did discuss transportation as well as linguistic and culturally appropriate services, as well as literacy, language, and discrimination. So what exactly can we do about it? As NCUHC embarks on the journey of reform, we are focused on efforts, that ensure the delivery of services meets the community where they are. So you're going to hear a little bit from our next speaker, Dr. Amy Martin, just how important community-based programs are. But we also work to close the referral loop. So we want to do that through care coordination and an interdisciplinary care approach. We want to utilize care teams as well that value the work of patient advocates. And so patient advocates is a term we did not coin, obviously, but we use quite frequently to really just discuss someone that is there to assist that person, that potential patient, in their journey from realizing that they want to seek services, but actually helping break down those barriers that they face for them to be able to achieve the services. And that's often the missing link. And then we also want to make sure that the reform that we're focused on influences the payment system. We want to accentuate and incentivize early prevention. And we also want to focus on value over volume. So the idea really moving towards a value-based approach. I did want to put this in. Folks have been asking about this, so I just wanted to take a moment. Obviously, there is teledentistry legislation at the General Assembly as we speak, and so that is being discussed. But in relation to meeting people where they are, we really should be leveraging technology. That helps to reduce access gaps and making sure that folks have, a way and ability to actually access a provider depending on where they are. And teledentistry obviously would be one step forward in that vision. So these really are the social determinants of health, or the drivers that we've mentioned earlier. And this is just kind of a way to showcase just how important that patient advocate model really is. So again, they are working to address anxiety, fear, and shame, which often is a large driver of where folks, are uncomfortable or unable or unwilling to seek services. Making sure that they understand the treatment plans that are being discussed. That's a problem that we see a lot, particularly with low literacy populations. They are not confused, but the provider often does not provide the information to them in a way that they understand. So that patient advocate really can help, foster that relationship as well and make sure that it's clear and that their questions are answered. And then lastly, making sure that community-based dental efforts are, supported. So I mentioned at the start of this content presentation, we're really focused on alternative access points. And so school-based programs is one of the obvious ones, and Dr. Martin, as I mentioned, is going to be discussing that. But really, let's think about where else could we deliver at least education and prevention. An ounce of prevention you've probably heard is worth a pound of cure. Why don't we utilize the access points that already exist to deliver some of those preventive services? That could include primary care offices, long-term care facilities, WIC offices, OBGYN offices, and the list goes on and on. So in just a moment, I'm going to turn it over to Dr. Martin, who will offer her insight into school-based programs, which obviously is a key component, as I mentioned, to our community-based dental efforts across the state. Please remember to submit questions for Q&A. We will make sure that we get to as many as we can during today's event, and then we will be following up, as I mentioned, to make sure all questions are answered. All right, so now we're going to turn it over to our next dynamic speaker, Dr. Amy Martin. So Dr. Martin is currently the chair of the Department of Stomatology and the director of the Division of Population Oral Health at the James B. Edwards College of Dental Medicine. Ooh, Amy, that is a mouthful. I don't know how many times you have to say that a week, but at the Medical University of South Carolina. She really has an impressive resume. Previous to her current role, she shared her experience and expertise as the Associate Director for the South Carolina Office of Rural Health, the Program Manager and Health Policy Analyst for the Office of Research and Statistics, and as Deputy Director for the South Carolina Rural Health Research Center at the University of South Carolina. We're honored to have Dr. Martin with us today to share her experience in building community-based oral health programs and their role in addressing access and equity barriers for children across the Carolinas. So Amy, it is all yours.
Thank you, Zach. I'm attempting to share my screen, so hopefully you're able to see it. Let's see. There we go. And yes, I have to say Dr. Edwards' name quite frequently, and his name is an excellent reminder of folks such as Dr. Ricks, that those of you who hold dental degrees, you are encouraged to consider public service. Dr. Edwards was a previous president of the Medical University of South Carolina, was an oral surgeon, but was a former governor of South Carolina. So, wow, what if we could have another dentist in the governor's office? I'm sensing a campaign ad for Zach Bryan. I will serve as his campaign manager. Thank you so much for having me. I am at the Medical University of South Carolina. South Carolina is my adopted home for many, many, many years, but my birth certificate actually reads Gaston County, North Carolina, and I'm a product of the North Carolina public school system. And if I was born today, would most likely be a patient of Dr. Donigan, who will come shortly after me. So it is an honor and a pleasure to be speaking with you all today. This is where I work now in Charleston, South Carolina. We have a 6th-floor dental clinic where we train almost 400 dental students every day, and a cadre of specialty residency programs. So in keeping with today's theme and building off both Drs. Ricks and Bryan's comments, there is this intersection of bringing care to the community but doing so in a way that does not perpetuate historical inequities. And so that is the theme of my comments this morning. I'm going to lead in with the epidemiological case, talk a little bit about the regional solutions in both Carolinas around school-based oral health programs, but drill down to the local level as well, because regionalization and epidemiological impact is only made possible when we have those local champions. And I'll share with you some findings from a school nurse study that we completed in South Carolina in hopes that can ignite and energize some enthusiasm for champion building. I'll share with you some next steps, the next generation of some of the work we're doing in our own rural communities here in South Carolina, and close out it with some priorities as we see it through our lens for advocacy and influence in both states. So we have really good news in a time when COVID seems to usurp the attention from traditional media outlets as well as the peer-reviewed publications. Oral health for kids, especially rural kids, is popular again. We produced a study earlier this year that was published in the Journal of Public Health Dentistry. We looked at historical disparities using the National Survey of Children's Health. And we have some good news, bad news that I'll just quickly introduce. But what was really good news to us from an advocacy perspective is in the things that our Office of Research looks at, this was one of the most downloaded studies for the time period in which it was published earlier this year, which is what tells us that there's a broad readership, not just within our niche of oral health advocates, but beyond, that this is of interest to many different diverse audiences. So that's good news. The other good news is I convinced a team of very junior young scientists to get interested in rural oral health. And so I hope that part of my legacy is to inculcate a passion for this type of research, for this topic and these populations that we're discussing in the next generation of health service researchers. So I'm excited about this team and what they've done. Very quickly, and I shamelessly ask for you to download and read the study, but the good news, the big picture takeaways is the work that Dr. Rick spoke about earlier is starting to manifest in some of our epidemiological data and evidence. Now, there's still plenty of inequities for us to be concerned about, but we are very excited to have found in the latest iteration of the National Survey of Children's Health that for preventive dental visits, the historical disparity of rural-urban has disappeared. That was a tremendous finding for us, and I give credit to the wheel that both Drs. Ricks and Brian referenced. As we chip away at that wheel, as we think about alternative workforce models, as we advocate for evidence-based reimbursement policies and really tighten and strengthen the safety net for kids, we see that impacting the epidemiological evidence. And I give a lot of credit to school-based programs. This nation has really embraced that as an alternative model to traditional care settings. And again, I credit that to leveling the playing field, at least for rural urban kids. Now, there persists some social determinant inequities that you would expect to see, but that rural urban difference ameliorating was quite significant, and we're excited about that. So continuing to give credit to school-based programs, I just have to celebrate, and I'll try not to get emotional about this, but I just have to celebrate my friends and colleagues at the Duke Endowment, the Blue Cross Blue Shield foundations of both North and South Carolina, and my research colleagues at East Carolina University. A small group of us came together a few years ago and said, what can we do that would just be of significant impact? And it was the expansion of school-based programs. And I'm still struck by the degree of faith that the partners you see on the screen had in each other to really be dedicated and stand up what has been a fantastic evidence-based curriculum, and partners, many of you who are on this call, who also gambled and took a chance to work with us to figure out what are the best ways to deliver oral health services in school-based settings for children who otherwise would not have access to care. So again, earlier this year, we wrote up our story, and it's a process story. So it's not necessarily packed with a lot of data. That story is to come in another publication. But this article published in the Maternal and Child Health Journal describes what we've done as funding and policy partners, also what we've done in partnership with many of you. So again, I encourage you to download it. And if you don't have access to it, feel free to email Zach or me, and we'll make sure to get you a copy of it. But it delineates what has worked well in North and South Carolina. We are especially proud that it was published in this particular journal, because it was from this journal that we drew inspiration. HRSA had funded many years ago a similar program that provided and set some expectations for us and some parameters that we then modeled much of our work in the Carolinas on. So our first cohort, our first brave cohort, which includes the friends and colleagues who are speaking after me, you see them across the map, and they really helped us fine tune and finesse how to strengthen these programs so that they optimized impact and did so in a financially sustainable way, so that these programs were not always dependent on philanthropic or federal sources of funding. The graph below you delineates the time and effort they spent on working through our technical assistance curriculum. And you can see there are some outliers for sure. And where we spend a lot of time working with our partners is figuring out the staffing model. How do we optimize people so that they can function at the top of their license in ways that bring the biggest impact to the communities and the schools and the children we're trying to serve? So fast forward 3 years later, we've got dots all over the map in North and South Carolina. Many of our investments in South Carolina have centered on the PD. Thanks to really good surveillance data, we're able to determine where there's some real hot spots of problems. Also, what predated our program in South Carolina was existing school-based programs that are run by a number of organizations in partnership with our public health agency. So the real lift has been in North Carolina, again, working with partners that are really motivated for change at the local level. So half the battle, I say half the battle, half the challenge is really getting and identifying good partners to deliver programs in ways that we know yield maximum access. The other is to have localized champions and have communities who are ready to receive. So in our own state, we did a study of school nurses in partnership with our school-based programs and our public health agency. And what we learned through a survey of school-based nurses is really quite telling, in that school nurses they might be the finest case managers around, and they are oftentimes not properly recognized for their role in oral health service delivery and problem identification. What we learned through a survey is that there's an awful lot of oral health interprofessional practice going on in our public schools. And so those school nurses who have that level of expertise, we see a much better performance and likelihood for a school-based program to come into those settings and serve those children more effectively. But the challenge that school nurses reported really had very little to do with access to dental services. And their principal challenges really were parent and family partnerships. So ensuring that when referrals are made or getting those consents to participate in school-based programs go unsigned, connecting with families and parents really is their chief challenge. one nurse in particular gave a particularly compelling story around a student who had a dental emergency. She had a student who was ready to be seen, a dentist who was ready to see that person, but getting the parent to close that treatment loop was a real challenge for a variety of reasons. And so this really has inspired us in our work with the partners I previously mentioned to stay the course, be that program that fills an access gap, but how do we include families in that process in better ways to improve the consent experience, but also to make sure that their own home behaviors and values around oral health get properly impacted. So here's a distribution of those scores, and you can see, based on the response of our school nurses, their biggest challenge in ensuring that their kids are getting access to services is lack of parent follow-up or missed appointments. There are some enabling service components to this as well, such as transportation, affordability or ability to care, English as a second language. So those certainly are pieces, but these are things that distinguish between what we can advocate for through legislation, through policy, through program enhancements. And then there's those things that we call our sphere of influence, and parent engagement and influencing their participation and championing in their children's oral health is something we can only influence and can't legislate. And so hearing from a school nurse that that's their chief challenge really has inspired all of us to think through our model a little differently and how we bring parents along with that. I will just call out anecdotally, and it's not my intention to necessarily call out any particular programs, but you have a program in North Carolina led by Sharon Harrell, who I think really gets that and embodies it in a real special, unique way. She has school-based services that she delivers in a fixed clinic model on site in a school. But given the built environment and the social determinants that she finds herself delivering care, has really figured out an alternative model that welcomes the entire family into the care delivery experience. And so we love partnering with Dr. Harrell and look forward to learning many more lessons from her as well as our other grantees. So looking to the future, as we accumulate the lessons learned, both at the national level through our regional work around school-based programs, and then those local champions, we are engaged in, in a systems level experiment in South Carolina. There was literally a fortuitous collision of opportunity that occurred in a rural community in our state, actually not far at all from the North Carolina border. Many of you may be familiar with Marion County. The healthcare system side of MUSC purchased a few rural hospitals that were previously for-profit. The for-profit entity was looking to sell. We saw an opportunity to be responsive to rural health needs in our state, so we acquired those facilities, Marion being one of them. And as we have come into that community, which actually started, the catalyst for this was the school-based work that we do in partnership with our friends at ECU, Duke, and Blue Cross. That work revealed a wealth of opportunity and partners to do something really big for rural. And I get that that's an oxymoron, but it gave us a chance to really think about and conceptualize something much larger than we ever expected. In our quest and sense of urgency to do something big, we try to remind ourselves of community context. I grew up in the textile mill villages of Gaston County and have worked all of my career in rural. So I am uniquely sensitive to community identity. And sometimes those community identities are in direct conflict with public health. And this is the case of Marion. Historically, Marion County has been the epicenter of the tobacco marketplace for our state and has held a prominent place in our country's history of tobacco. And because of that, when we in public health think tobacco, we think about the public health and the clinical ills of tobacco. tobacco, whereas this community views it through a very different lens of a prior time in their history of economic prosperity. And there is still a dedicated festival time for celebrating it's the Golden Leaf Festival. Some of the generational impact of this, though, as you can imagine, is pretty significant chronic disease rates and pretty significant oral disease as well. So negotiating the positive and the negative impact on tobacco on community context is something we're especially sensitive to. So this is all the darts that we threw onto the dartboard in my office, which is really a whiteboard with lots and lots of colors. And we did an asset map of what resources do we have? What are the threats to addressing the oral health of what started out as just school-based, school-age children evolved into this bolus of opportunity. So I'm very quickly, for the sake of time, just going to unpackage. On the blue side is the school-based model. That includes school-based programs in 2 different school systems that all feed into Marion County communities. These also include referral partners that include private practices, community dentists, an FQHC, and a hygiene-only program. We separately, as MUSC, are experimenting with a different application of hygienists. We are going to co-locate hygienists in primary care settings. Our Practice Act authorizes that under public health supervision, and we're going to experiment that with the rural health clinics that we own and operate as MUSC. So these 4 players are going to work together to literally tighten the weave of the social net, of the safety net network, to make sure that kids are indeed getting identified, getting into care, and not being lost. One thing that was missing from this system was OR, addressing the surgical needs. And so back in Charleston, when we're looking at our pediatric dental residency program, we have an awful lot of traffic coming into our OR from the PD region, from Marion County. So gratefully, in partnership with Duke and with Blue Cross, we're now planning the deployment of an on-site rotation of our pediatric dental residents in the hospital that we own. So we own the hospital in Marion. As luck would have it, there is a vacant OR suite that nobody's using. It's plumbed and primed and ready. It just needs to be equipped with surgeons. So we are doing our ground game now, working with the partners in the blue box to determine what might be a good protocol for referring, managing, and ensuring that kids who need that level of tertiary care get it, so they don't have to travel the 2.5 hours to Charleston. We can travel to them. We are also exploring other surgical specialties, but we're starting there. I've just also got to say, in response very quickly to Doctors Brian and Rick's workforce issues, we as the state's only dental school have prioritized some learning and educational programs that we hope will open the pipeline for rural practice and safety net dentistry. One is a fellowship in rural dentistry. The second is a degree completion program in public health dental hygiene. We don't have a baccalaureate program in our state like you all do. We have a fantastic network of technical colleges that do a great job of training hygienists. We do not intend to compete. What we have intended and already spoken with them about is how can we augment and pick their students up at graduation to ensure that they complete that. What we have found in our workforce is a real need to equip hygienists with that interprofessional acumen and the ability to facilitate and coach in integrated care treatment settings. So we also have a safety net certificate program that we have historically offered to our dental students rather, and we've repackaged that for CE reasons for the region's dental workforce. So in closing, through all of these wonderful opportunities and partners that I get to work with on a daily basis, if I could implore you all to think about advocacy priorities as it intersects with community care and health equity, I have 4 asks. My first ask is to continue to strengthen and support the rural safety net dental providers. The second is to continue to work closely with Medicaid and Medicaid advocates to ensure that dental benefit design reflects evidence-based clinical practice. Sometimes these things get antiquated. Sometimes they don't always espouse evidence-based practice, and the science is continuing to emerge at a much more rapid pace. So we owe it to our children and our families living at lower income levels to advocate on their behalf. Third is to encourage policy that facilitates innovation and that prioritizes those applications at the population level. Telemedicine and teledentistry is one of those. We have a whole that's a whole nother presentation we could talk about, but teledentistry absolutely being one of those. And last but not least is strengthening the oral health surveillance. The states, I think, do as good a job as they can, but this is really a national priority. And so shamelessly, while I have Dr. Rick's attention, this is a space that I think many of us have been advocating for that's been a sort of a slow roll. And that's probably because most oral health policies are promulgated at the state level, not the federal. But this is certainly a space we need to advocate for. And in closing, one thing I'm continuing to put pressure on my own program officers at either NIH or at HRSA is, golly, we really need an oral health strategic plan for the U.S. Department of Health and Human Services. We had a great one that expired in 2017. And so my hope is if we collectively continue to advocate for that, that will give us all a framework to continue to do the good work and the good research we're all doing, but do it in a coordinated, purposeful, directional way. I did it on time, Zach. I really need extra points for that because I can barely introduce myself in 20 minutes.
Amy, you did such a fantastic job. I am so grateful for you joining us today and sharing all the great content that you did.
Thank you, Zach.
Okay, and so now we're going to pull it over to our last set of speakers. So please join me in welcoming Dr. Bill Donigan and Melissa Boughman. So Dr. Donigan's the dental director for Kintegra Health. His experience in public health spans more than 23 years. And Melissa is his dental access program director for Kintegra Health, and she is a dental hygienist and obviously a passionate advocate for oral health care access. They're going to lead us on the journey to emphasize just how important dental care coordination and case management really is. So I'm going to turn it over to you all.
Thanks, Zach. Hopefully, that wasn't the one. I hit the wrong one. Is that full screen or not, Zach? I can't tell.
It's not.
Okay, great.
Yeah, Bill, just go to end show. I think you're in presenter mode.
No, it's not doing it. It's
So
not.
to the right of that, there should be display settings and then end slideshow. Let's try ending the slideshow and then resharing.
No.
Nope, not there. Okay.
There it is. I got it now. There we go. Let's try again. I just hit the wrong button.
That's okay.
How about this one?
There we go. So, yep.
Okay. That better?
Yes, excellent.
All right. This is actually my second slide because I think this is the #1 health inequity. 3.5 billion people with a toothbrush and 6.8 billion people. So we have, 47 or 48% of the people that don't use a toothbrush. So, and I tell you this because my belief is the best opportunity for prevention is the community health, dental health coordinator / navigator / oral health advocate, especially here in North Carolina. And I talk about a lot of populations when I talk, people with intellectual and developmental disabilities. I have a lot of HIV patients, HPV patients, pregnant women, but as has been brought out, what about our seniors? Medicare offers no true dental services, but mainly what we're going to talk about today is integration, medical to dental, and also our school-based programs. So you can't look in your rearview mirror. We've got to go forward, baby. That's the only way we can get there. I was a clinic child. I expressed earlier to Dr. Ricks, I was a Navy child, first generation college, graduated from Marquette, went to University of Illinois for dental school, University of Kansas for my MPH. I spent many years, 25 years roughly, in private practice, and somewhere in the midst of it, I got into the public health side and fell in love with it. I want to introduce you now for this next slide to who I consider to be the original CDHC in North Carolina, Melissa Boughman.
Hi, yes, I'm Melissa Boughman. I am part of the school-based program, loving it. It's been a wonderful, awesome journey. I did attend Central Piedmont Community College, and I was in private practice for a while. And then I went to Eastern Airlines to do a little something different that time, and went back to private practice. And I've been the dental hygienist for Gaston Family Health Services. And then it turned into Kintegra, which is the same office, just a different name, and the dental access coordinator, and have been the director of the dental program here at the present.
So since I'm from Kansas, I get to lead you down the yellow brick road of how this all works, and it works for us. Gaston Family began as medical services only in 1992 with a $500,000 grant from the county and Gaston Memorial Hospital. We've now grown to 40 times. We are in 10 counties, and 1 in 8 people in Gaston County see us for medical or dental services. Dental was added in 96, hospital dental in 2000. We got FQHC status in 2002. Our pediatric dental opened in 2004. And right in the midst of the pandemic, we changed our name. So that's always fun. Today we have 7 fixed sites, and we have about 38,000 patient encounters annually. ECC is something we all talk about. Those of you who aren't in dental or not specific clinical, its prevalence is epidemic, highest in minorities and rural populations. As much as 70% of kids have ECC. What's wrong with health, and what's wrong, I guess basically it comes down to health equity or inequity in the United States. They have oral diseases and disorders affect health and well-being, not just at the time, but throughout life. They're associated with other health problems. There are safe and effective measures to prevent most common dental diseases. We just need to get that other 47% to use a toothbrush. Pretty common. Lifestyle behaviors. Amy talked about tobacco, but tobacco and vaping with our kids, excessive alcohol use. Melissa gives a presentation. I always think it's great because, you know, our kids in this area love Sundrop. Sundrop has, in a 20-ounce bottle, has 16 teaspoons of sugar. That isn't going to affect your teeth? You know it is. Profound and consequential oral health disparities across, and you've heard about that from Dr. Bryan and from Dr. Ricks and from Amy Martin. You've heard it from everybody. But the mouth affects our general health and well-being. And when I got out of dental school in 1983, very few people were ever talking about how oral health affected general health. Now we're really starting to talk about it. This slide was kind of interesting. I got it from Blue Cross, and People with oral health issues twice as likely to have visits to the ED, 25% greater heart disease issues. Bottom line, they lose a year and 7 months or 1.7 years of healthy life. Dr. Rick showed a different slide. I've used this one for a long time. This is back in 2011, and the reason I like it is because it shows little kids, and that's our big focus in a lot of our practice is kids. 60.3% of 108 million kids had a physician visit and no dental visit. That's a problem. When I was out of school, we didn't see kids until they were 3. That's too late, way too late. And I always ask practitioners, how many times, especially in the FQHC level, how many times have you thrown away your call list because your contact information is no longer relevant? The phone isn't the same, the address isn't the same, whatever it is. But we use community health workers. I say they're navigators, oral health advocates, whatever you want to call them. But they're our eyes and ears out there. They are in the medical field. They can and should address oral health care, from babies to pregnant women to seniors. They can bring the relevance of good overall health to the community and those living in it. Prevention and education should be, must be, their tools of the trade. So guess what? Let's look at it differently. Let's not just sit in our brick and mortar dental clinic and wait for them to come to us. You know, we talked a little bit about barriers, and I talk about transportation. In our clinic here on Hudson Boulevard, vast majority of the patients, they use cars, but we have a lot of them that take the bus. We have a lot of them that walk from public housing. Childcare. Always loved it in practicing when the mom is in the chair with a 3-year-old in her lap and lets the 3-year-old down, and the 3-year-old's walking around my operatory. That's hard, but she can't get daycare or she can't bring her child in. Finances, many of our patients can't even afford the nominal fee we have. Medicaid reimbursement hasn't changed much, and it's one of the big things that the ADA and everybody else talks about. And telephone, you know, we've gone through patients who have pay-as-you-go phones, can't get an email, can't get a text, can't talk. That's their only computer too. And probably the one that I've seen the most recently is the fact that due to COVID and people losing their jobs, they lost their dental insurance. And I know that Dr. Ricks and Dr. Bryan talked a little bit about barriers to care because of cost, but the Health Policy Institute just came out this week and said that cost was a barrier to care in ages 19 to 64 in 32% of the under 133 FPL level. So a third of those people are foregoing care because they can't afford it. And 24% in the 133 to 399 level. So there are a lot of people foregoing care. And in our seniors, the low income, it's over a quarter. So those are scary numbers to me. So what other barriers? We've talked about health literacy. I know everyone talks about it. Cooperation with provider instructions. I don't know how many times I have walked out of our clinic and found the bloody gauze on the way out to my car. Patients don't necessarily understand everything they're being told or what they're being taught. If you've been around me long enough, you know that I only believe there's 3 important things we do, and it's education, education, education. Many of our patients are first timers or only come in when they're in pain, and many of them were raised that way. Dr. Martin talked about Gaston County. I can tell you that a lot of those patients will tell you, we only came to the dentist when we were in pain. That's the way we were raised. They have a lack of discretionary funds. They can barely afford the basics of life, let alone the medications that they need. So we developed back in 2012 a program called CHOP, Child Health Outreach. And the goals of that were to educate the caregiver and children about oral health, caries transmission, pediatric dental specialty care, and especially that 1-year visit. About relieving the burden of accessing care. That navigator advocate actually has a computer with them and can actually schedule right away in our clinic. And they can schedule with us, they can schedule at the closest clinic, they can schedule with a pediatric dentist. Our whole goal is to integrate that oral health visit into the medical visit. I added the word dedicated because I'll be real honest, we have 8 navigators right now, 4 that are in either pediatric medical facilities or a WIC in a maternity clinic. And then we have 4 that are associated with Melissa's program. They have to be dedicated. If we don't have dedication, we don't have a way to make this work. They have to have some office space in the pediatric medical facility. They just need a laptop and a wireless internet connection. And salary and benefits are provided by us, the dental clinic, and everything's funded by us. The medical clinic then will get to bill for the fact that this navigator, child health, oral health advocate is placing fluoride varnish, and they bill for that. We began in 2012. In that first year, we received 512 new patient appointments. I don't know of any practice in the state of North Carolina that doesn't want 500 new patients in a year. We started with about 64 new patients a month. Now we're over 1,400 annually every year with a show rate of greater than 85%. We started initially by using a small PowerPoint slide that Cindy would show to the parents that all dealt with oral health education, and voila, we had success. 75% treatment completion within 6 months, sealants placed on the molars, premolars, and primary molars. This is Cindy at work at all ages, and the end result was no pain. Whoops, backwards, wrong button. No pain. So everyone says to me, well, we just build it and they're going to come. And so did our management. And they built a pediatric medical facility touching at one of our dental clinics. Oh, we don't need any navigators. Everything will work, sort of. This is 2016 with Cindy. And this data comes to me every month based on what they do, declines, uninsureds, number of appointments kept, how many were insured, how many were made, percentage kept. If you go back to that, she had in 2016, she brought us 900 new patients. Who wouldn't want 900 new patients? Well, how important is that navigator? In 2016, at our Statesville location, where we had a pediatric medical facility touching our dental facility, common waiting room, common front desk, everything, they referred almost exactly the same number of patients. Guess what? Only 47 crossed over to the other side to make an appointment on the dental side, even though they had a referral. So what ended up happening was we put a navigator in that site, and in the next month after the navigator was there and trained and in place, 50 new patients from that site. So in 2012 to 2016, we got 4,584 new patients in our practices. So, my job as director is to fulfill the mission of Kintegra. That is to treat the uninsured and the underinsured. But guess what? That costs money. So we treat Medicaid and private insurance. And if we do it at the right balance, we get sustainability. So we also started a program called Dental Access. And at first we didn't have navigators. Now we do. And I'm hoping Melissa will smile on that one because she knows how important those navigators are. I'm an acronym person. Access was achieving childhood dental care through an excellent school system. Melissa and I agree on these 4 things: make it fun, the patient responsibility, education, 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 and for our staff to be very flexible in what they do. Melissa works to resolve barriers, increasing education within the community, and increase access to services. She worked with the Director of Health Services in Gaston County initially when we started this program, and now works in 4 or 5 counties, Melissa.
Well, 7 school systems,
7.
right, with 4 counties. Yeah, right, 7 school systems.
So it's a big program now. She works through the school principals and the school nurses. She discusses all the protocols with them. She is a CDHC. She writes a letter. She works with the schools individually to coordinate these visits. A year before COVID, we would see 20 to 25 students per visit of our mobile dental units. With parental consent, it's dropped to about 15, but the students are only there 40% of the time. So I think that in itself has made a big difference, but we're hoping come September that we'll be back on our normal tilt. So Melissa?
Hi, thank you. In 2006 is when we initially began. We actually went to Head Starts. We mainly did screenings. We just kind of got in and we did exams if we could, but a lot of times it was mainly screenings. Now, in 2021, we saw 3,384 school children for dental evaluations, x-rays if needed, dental photos, prophies, fluoride treatment, and possible sealants if time prevailed. In 2020, we saw about 5,500 children, but that's pre-COVID, and that was until March when everything had to stop. Everything shut down. In 2007, the schools came to us at our main clinic from 9 a.m. to 12 noon for about 12 years. It became increasingly difficult to find bus drivers. 2 teachers had to chaperone per visit, that's per the school system, and also funding. So it became a little more difficult as time was going by. They wanted to come, it was just hard for them to get there. The advantage while waiting their turn is the children enjoy group dental education. As Dr. D said, education, education, education. They might come in a certain way, but hopefully as they grow and they learn, it won't happen again, and hopefully not to their siblings either. Visual education is so very important to children, well, to all of us, but mainly to children. We would show how much sugar is actually in a soda. We would turn it upside down and they would just go, oh, they couldn't believe it, and especially it's teachers too. And also we would show them the water, that there's no sugar in the water. And definitely be silly when you're talking to children or being with children. So using a repetitive jingle helps a lot while clapping. Like I would say, we're going to brush. I would have them stand up and go, we're going to brush every morning, every night, every morning, every night. They get that jingle in their head and they love it. The same thing with milk and water. And you just make a jingle out of it. Let them stand up, let them participate, just be silly. And so, yes, they both love it, teachers and children.
We've had some changes, and Dr. Bryan talked about it in the last 2 years with the Dental Practice Act. And I'm not going to go into it, but we have utilized 16W and 16Z to the best of our abilities within our practice. We use the advantage of 16W in our schools. And now we've changed our whole model of how we get out there to the schools. So, Melissa?
Yes, and in 2017, the real fun began.
Yeah,
we got the bus, the mobile dental unit.
No, you can't use the word bus. Robert will get you.
You saw me change up. You saw me mobile dental unit.
And in 2019, thanks to Blue Cross Blue Shield Corporate, we were able to add a second bus for actually Gaston and Lincoln counties. The first bus in 2017 was for Catawba and Iredale counties.
There are 3 chairs on the mobile dental unit. We make sure that all children are always having fun, comfortable, and safe.
And in this last summer, we purchased from the North Carolina Dental Foundation their mobile X-ray bus that they used at Mission of Mercies, and we're turning it into a 2-chair dental bus to serve Davie and Davidson counties. That will be in operation September 1.
We complete the preventive services while we're on the mobile dental unit at the schools. Our plan in the future is to use SDF and for the posterior teeth with the parent consent. Children always leave with a goodie bag and a parent form that tells them exactly what was done on the mobile dental unit. And it gives our information for them to call, but we call them as well.
Yeah, one of the big things that what I want to express is there's many parts to what we're doing. Our hygienists and dental assistants are charting. They take a series of 9 photographs using intraoral cameras. They take x-rays as per AAPD guidelines. Those are both uploaded to our Dentrix Enterprise electronic dental record. They complete a scaling and prophylaxis on every child. They place fluoride varnish and glass ionomer sealants if they can, or if there's time. Then that information is logged into Dentrix for the treating dentist, which means that if they're in Catawba County, it's going to the Catawba site. The dentist will evaluate the x-rays, evaluates the photographs, and develops what I call a tentative treatment plan. They can adjust that treatment plan when they see the patient in chair. And the case is referred to our DAP Dental Access Program Navigator. That navigator will telephone the parent and attempt to schedule an appointment with the treating dentist, the dentist who developed that tentative treatment plan. An appointment is scheduled and treatment appointment is accomplished. The kicker to a lot of that, Melissa will attest, one of the things that we've learned is that we actually try and contact that parent morning, afternoon, evening. If we don't, we put a card out to that parent. If not, they stay on a list where we can go ahead and keep calling them to try and get that patient in. So it's fun that way, but the most important piece is the navigator.
This actually just talks about what Dr. Donigan said, so we can go ahead and move past that one.
I'm sorry, Melissa.
No, that's fine. Just kind of just.
I know we're in a time crunch, and
yes,
one of the things, if any of you use Dentrix Enterprise, you'll notice that several of these teeth have pink. We use pink as conditions because hygienists cannot diagnose. They can mark areas that they want us as the dentist to look at, and they do. And they mark them as a condition. And then the dentist, in their evaluation, their tentative treatment plan can change it, or they can say, we'll look at it again when the patient gets in the chair. So that's very critical to what goes on. These are what we call emergencies. Melissa and I, during the school year, we get these every day, 4 or 5 a day. They look like that. And what happens is the hygienist on the mobile dental unit will then contact me, contact Melissa, contact the local provider, and they schedule an appointment. The most exciting part to me of this whole process was that this last year we had one child who was in the chair at 10 o'clock complaining of pain, 10 a.m. At 2 o'clock, the tooth was being treated. That's exciting. That's what it needs to be. So Melissa and I started this, and I'm going to finish it, Melissa. We started this in about 2008, 2009, somewhere in there, with giving away 2 bicycles. In 2019, we gave away 10. So we're continuing to get the children involved. And as you notice from this picture, the parents come to see this. So Melissa gets another chance at the education. So I tell you this, think outside the box. What are your ideas? How do they fit? What are your relationships? For us, Mainly it was county health departments and other organizations that we could work with. Now it's our own FQHC, but we work in one of our navigators is in a WIC. One is in a private maternity clinic. And understand something. I told our staff when COVID began, we live in a giant PDSA cycle. We will plan, do, study, act. We will constantly be changing. We can change from right away at 8 a.m. It can be different by noon. The whole process has to change. And you're going to always have change and evolution. And I always put out my favorite speaker's comment: when the pain of staying the same becomes greater than the pain of change, you will change. So thank you.
Thank you.
Bill, thank you both. Melissa, thank you. Bill, thank you as well. Did you draw that picture on the previous slide that you love the dentist? Is that your drawing, Bill?
Yes, that's about how artistic I am.
All right, so I'm going to close us out here. I know that we only have a few minutes left. I'm happy to say that we've really not lost anyone, actually. People are staying engaged, so that's really exciting. Let me go ahead and share again. All right, so I did want to close us out by just making you aware of a couple things. At the North Carolina Oral Health Collaborative, we did just recently launch an advocacy platform called NC for Change. And so I highly encourage you all to check it out. The membership is free. It's oralhealthnc.org/NC, the number 4 change. And it's a way for us to really stay connected, particularly as it pertains to NCOHC priorities for legislative change or regulatory change, needs of community, and really what you're hearing on the ground and what you would like to see advocated on behalf of. I also want to let you all know we will be actually launching an equity summit in the spring of 2022. So we're really excited about this, to bring together, a group of dynamic speakers and panelists to really further, explore and extrapolate on some of the content we discussed today, but particularly around how it impacts equitable access and then thus equitable outcomes for all populations. Our contact information is shown here. One of the major benefits of being in this role in North Carolina is you all are so engaged. We love it. We love having you reach out. We love connecting with you. I'm really hopeful that we'll be doing that more in person soon. But if you have questions, don't hesitate to reach out to us. Send us an email. Make sure to join our email news list. That will get you access to all the content that we release. You can do that at oralhealthnc.org/join. We are on all social media platforms, including Facebook, LinkedIn, Twitter, Instagram. And then we are not very creative sometimes. And so you can text the word teeth to 917-905-8801, which will automatically enroll you into e-news if that's easier for you all. It has been such a wonderful time that we've had today, and I really want to thank the speakers again for all the content and wonderful presentations that you provided us and the audience with. I'm hoping that it'll spark some ideas and really generate a lot of excitement around how do we create the systems level change that we are all hoping to achieve. We did have a few questions. I believe the majority of them we have answered in the Q&A live, but I do want to take a moment, Sarah, to hand it over to you if there are any questions from the Q&A of participants you want us to address before we close out.
Excellent. Thank you, Dr. Brian. We did have one, and this one came through. We've had a lot of questions that were answered live. Again, if we did not get to your question, we will follow up with you directly via email and try to coordinate those details for you. I did want to just state, before I ask that question and you dive into that, Dr. Brian, I did want to state that we did disperse our 6 raffles today. So thank you for participating. We communicated directly with each person who won. So that was, I hope that you all enjoy those gifts. And thank you for joining us today. All right, so your question is, at one time, the collaborative advocated for expansion of the oral health section, since public health hygienists can legally already deliver prevention services in the community. Is that still a priority? And will monies for the section be guaranteed to deliver more direct services in the field or for administrative positions to develop new programs?
So Sarah, that's a great question, and thanks to whoever did ask that. At the collaborative, we do advocate on behalf of the oral health section. The oral health section, as many of you know, the workforce has been cut. So our purpose in advocating is for state appropriations. And so we do have conversations with our state legislature about how very important the oral health section is to public health efforts in oral health across North Carolina. So yes, we do. We have and continue to do so. We also understand that there are, workforce challenges in terms of state dollars that can be allocated or that are being allocated, I should say, to DHHS for the oral health section and the field staff. And we're really working on kind of a balance to make sure that both the oral health section workforce is supported, but also that we're looking to expand access to preventive services by other safety net entities such as FQHCs, local health departments, free and charitable clinics, et cetera. So yes, we very much value the oral health section's work and love partnership with you all and hope to continue to strengthen that going forward. If there are any other questions that we did not address, please feel free to send us an email after. There were several questions asking to get slides from today's content, so we will follow up with speakers after today's event just to get consent to actually send you the slide deck if that's what you're hoping to see. But the recording from the entire event will be available shortly after the event up on our event webpage. And so you will be able to replay, stop if you need to jot down notes. You probably saw the speakers are highly engaged and very excited about the work that they do in the different sectors. And so I'm sure that they would all, very much appreciate and welcome, questions or ways to connect with you after the event as well. So I again want to say a thank you for all the folks that joined us today, to the NCUHC team as well. And then I also want to send a sincerest thanks again to both Dr. Amy Martin, Dr. Tim Ricks, Dr. Bill Donigan, and Melissa Boughman as well. I hope you all have a great day. We're only 2 minutes after, and we are still almost exactly the number we started with. So you guys are highly engaged. We love it. Please reach out if you have any questions. I hope to see you on the NC for Change platform, as well as at the Equity Summit in the spring of 2022. Talk to you all soon.